All right. So this is a 35-year-old lady who, we saw first as an inpatient, as an outside hospital transfer. She was initially diagnosed with TALL while she was incarcerated, in the prison system, worked up there, and then brought into a local hospital for a workup. Found to have an initial white blood cell count of 278,000, had anemia, thrombocytopenia, and on imaging had a 6-centimeter mediastinal mass. She was very quickly transferred to Tampa General after evaluation in her local hospital, and bone marrow biopsy showed 90% involvement by T, acute lymphoblastic leukemia. She had a normal karyotype, or her FISH showed a TRB rearrangement, and kind of going through her short, I'll let Dr. Albitar talk about her sequencing data, but kind of going through the rest of her story. She started induction therapy kind of based on standard TALL induction protocol, ALL-0434, which is a multi-drug chemo regimen, with the intention of incorporating nelarabine kind of in consolidation as well. Unfortunately, she was lost to follow-up during her induction therapy. We didn't see her again for a while. She ended up getting admitted. We've kind of found out all this after the fact, but she ended up getting admitted locally to the initial hospital again with appendicitis, had an appendectomy, went home, but then was readmitted to the local hospital again 2 weeks after the appendectomy. So this is a month after she was lost to follow-up with us. Had a white count again, almost 400,000, clearly with relapsing leukemia. Because she was off therapy for so long and never actually got much of her initial induction, we decided to re-induce her with the same regimen. And unfortunately, that did not work as well as we had hoped. Within kind of 2 weeks of reinduction, she had rapidly progressing, initial response clinically, then rapidly progressive disease. Started her on salvage therapy with a second-line multi-drug chemo regimen with nelarabine, etoposide, and cyclophosphamide. Thankfully, she actually responded well to that. Post reinduction, had a morphologic CR and was MRD positive by an NGS assay by clonoSEQ, about 10 to the -3 MRD positivity. Unfortunately, her pattern continued. Her second cycle of nelarabine, etoposide, Cytoxan was delayed because of missed appointments, and she had kind of worsening peripheral disease before making it to cycle 2. So clearly, very aggressive disease clinically at presentation, and then clearly not having a lot of time with remission despite chemotherapy, and then highlighting some psychosocial issues that caused some significant delays in her treatment. But we'll pass it on to Dr. Albitar to talk about her sequencing data. Actually, it's interesting here because we have her initial, but then we also have her relapse data as well.
So this is from the first sample in January, actually, where I think this is after a treatment, and all what we see here actually is mutation in KMT2C, and she had the EBV viruses, but we see clonality actually with TP7, T cell receptor beta, V7 and V3, the gamma, beta and gamma, they are clonal. So that suggests there is a T cell disease. And this is actually what we see here. So this is at that time. If we look at here markers, so we can really see that if we look at CD2, there is high level of CD2, there is increased T cells, no question about it, but there's no increase in CD34. There is TDT, mild increase in TDT, as you can really see here. And but we can really demonstrate the clonalities by RNA expression at that times for T cell alpha, but it is not really clonal or we cannot really call it for sure it is a clonal because it is not tenfold higher, but we can really call it that there are 2 clones for the beta and there is 1 clone for the T cell receptor gamma. This is when she came back, actually full relapse, and we see mutation in PTEN. We see also germline abnormalities here, on the RNA. But at the same time, we see autosomal chromosomal analysis shows 9b deletion, which include homozygous deletion of CDKN2A and small deletion on chromosomal thing. But more importantly, actually, we see the translocation here, which is the major one, include MYC gene translocated into the T cell receptor beta. So instead of the immunoglobulin, in this particular case, it is translocated to the T cell receptor beta. So it is similar to what we see in MYC rearrangement in B cells. And at the same time, we see a small deletion on chromosomal 9 on the B part of chromosomal 9 that include the MTAB gene and CDKN2B fusions. So if you look at the chromosomal abnormality, as you can really see, very small chromosomal deletion on the 9 that includes the CDKN2A, and on the 10, we see only deletions in the practically in the gene PTEN. So here's practically what we can really we can quantify the copy number with next gene sequencing. So as you can really see here, it is homozygous deletions for the CDKN2A because it goes from the normal, what we see in median cases we test should be about 2 because it represents 2 copies. But here we are seeing less than 0.2 copies, which means like both alleles are deleted. In contrast, for the PTEN, it is one allele is deleted, and as I showed you, the second allele is mutated. But more importantly, looking at the practically flow cytometry, but molecular flow cytometry. So as you can really see here, both samples, they are shown here, but this is actually the very first sample, and this is the second sample here. And you can see in the second sample, the expression of MYC is significantly high as compared to the normal, and that's because of the translocation into the promoter enhancer of the T cell receptor beta. And then you can really see there is no overexpression of CD34, but TDT is positive, as you can really see it here to some extent, and LIF1 is also high expression in these cases. So, as I mentioned, there is a deletion of one allele, and there is a mutation in the second allele for the PTEN, and there is the expression actually, as you can really see here, on the RNA, the PTEN is the mutant allele is expressed at very high level, or what looks high level, because the second allele is deleted completely. So most of the expressed is actually coming from the mutant. And here's actually the clonality for the T cells. It's really borderline clones, especially for the T cell receptor beta. So it's you can really say there are 2 clones that they are dominant, but again, the expression of the T cell, because it is acute lymphoblastic leukemia, is very low. Unlike what you see if it was mature T cells, the expression will be significantly higher than this. And this is actually the translocation of the MYC, as you can really see it here, translocated to the enhancer promoter of the T cell receptor beta. And this is the second translocation that involve actually the MTAB with the CDKN2B, as you can really see it here. And so Clearly, MYC rearrangement in T-cell acute lymphoblastic leukemia is very important, and in many cases, actually, you really don't really need the MYC, or if you have the MYC, you don't need the beating. But this patient has two abnormalities. The beating is abnormal and the MYC is abnormal. So this actually very aggressive T-cell acute lymphoblastic leukemias with abnormalities in both beating and MYC.
Yeah, thank you. And then, just another kind of practical point in how we apply this data for patients, right? We're not yet using this to change upfront therapy necessarily, but we may be getting there, right? So there was a great paper published by a French group in Blood last year, and they really looked at, two big clinical trial subgroups of patients that got high-intensity AYA-based induction regimens for T-ALL specifically. And they tried to figure out what genes seem to play the biggest prognostic roles, right? How do we subclassify these patients, like what we were talking about with lymphomas? And really, they found a handful of genes, some that seemed favorable, like Notch and FBXW7, and then other adverse risk genes like the RAS family, P53, Icaro finger mutations, that really led, initially they kind of divided into two groups, high risk and low risk, and then they said, well, we need to incorporate some clinical data into this. So they added genomic data with elevated initial blood count and the MRD response after initial induction therapy. And they found that by kind of incorporating these three factors, kind of initial clinical response or initial clinical outcome and genetic data, they were able to really find three subgroups. And you can see on the bottom right curve here a significant difference in these patients' outcomes, right? Patients that had good risk disease that were MRD negative after induction did really well. And unfortunately, the yellow curve, patients that had adverse genetics and adverse white blood cell count, lack of good MRD response, had a 50% survival or 50% risk of relapse over time. And so really the question here is now, as we design trials moving forward, how do we use classification systems like this, which incorporate genetic data, and potentially try to change our upfront treatment strategy, right? So should we add, for example, on these trials, these patients did not get upfront nelarabine, but now, should we add nelarabine for these patients? If someone's in the high-risk group, this is a population that I would say I would really want to try to get them to an allo transplant if I can. And maybe the low-risk group, I would say maybe we don't need to take them to allo. Maybe we can avoid that and just watch them. These are all just hypotheses. These are questions that we need to answer, but I think this is the first step, is creating some classification systems.
By the way, the PTEN mutation, put it in the classification of PI3K deficiencies.
Same pathway, absolutely.
Right.
Absolutely.
But again, this classification doesn't have the MYC. And I think the MYC will add a whole new level of high risk.
Yeah, absolutely. No, more work to be done for sure, but I think we're getting there.